today. This is your natal cleft, the up and down part, also referred to as the vertical smile. And the two folds, not really, the two folds up underneath it though are called the gluteal folds. So the natal cleft is really called the natal cleft, your butt crack. If you notice the different regions of the lower extremity, the pelvis and lower extremity, we've got the hip region, the gluteal region here. The thigh is the part occupied by the femur. And then the knee, and this is the leg. I think I mentioned that on the first day of class when we talked about orientation. And then the ankle and foot. The coxal bones, these are the three coxal bones that we've already been over. We know the different pieces and parts. Here you can see the three coxal bones come. Are we okay?
You skipped the
You
slide.
skipped the funny slide.
Huh?
You
You
skipped
skipped
the
this slide.
Oh, that guy. He's in the third year class. I don't know if you guys yeah, it's looking through. Huh, that's odd. Okay. Well, here we go. Why is this guy in a box? That's what I want to know. Why is he in a box?
It's funnier in a box.
It highlights the natal cleft.
It does. You can see that. If he wasn't in it, if he was just looking at you, you couldn't see the natal cleft. Okay. I understand now. So we know the different pieces and parts of the coxal bone, and I mentioned the other day that the three come together to form the acetabulum. If you look at the acetabulum, it's got a horseshoe-shaped articular surface here. That's called the lunate surface. So the ball of the femur does not articulate with the whole acetabulum. It's just with the lunate. It just rotates around the lunate. And the opening of the horseshoe is down here at the bottom. That's called the acetabular notch. It has a ligament that crosses it called the transverse acetabular ligament. You'll see it in the subsequent slide. If you look at the femur itself, the proximal femur, you've got the head, the neck is here, and then you've got a lesser and a greater trochanter with a little crest that runs between them. Not a groove like up in the humerus, but a crest that runs between them. That's called the Intertrochanteric Crest, right there. Okay. On the back side of the femur, you have these two ridges. Together they're called the linea aspera. That's where your gluteus attaches for the most part, well, for half of it. The linea aspera has two sides that come down, so there's a medial and a lateral lip. I don't care that you know that. Know that that ridge is the linea aspera. One thing about the femur that you should know is that femoral fractures can occur anywhere up in here at the neck or down here below infratrochanteric. These things are, they're tough, you know. Hip surgery now has come a long way. It used to be when you went in for hip replacement surgery, you were down non-weight bearing for weeks and weeks and weeks. Now they get you up the next day. But it's an extensive procedure, as you can imagine, with all the muscle mass around it. These are the dermatomes of the lower extremity, and there's not, if I skip a slide because of this thing, let me know. They're a lot more messy than the upper extremity. It's a lot more messy. You have areas, you know, the lateral femoral cutaneous nerve of the thigh, we know that. There's an anterior cutaneous nerve of the thigh, a posterior cutaneous nerve of the thigh, and so on. I don't think you should spend time memorizing this because there's a lot of variation in how they're presented. Here's one way, here's another way that's more linear or spiral. Yeah, I don't think you should spend much time looking at this, other than knowing that the lumbar nerves are going to supply the lower extremity. There are a couple, though, that are kind of interesting. And those are the terminations. One of them is the sural nerve that supplies the sensation in the back of the leg right here. The sural nerve, that's this one right here. Sural nerve. And down on the foot, you have three nerves that make it into the foot. There's a deep peroneal and a superficial peroneal. The deep peroneal, if this is your foot, that's your foot, big foot. The deep peroneal supplies a little triangle right there. This is the top of your foot. So that's the deep peroneal. The superficial supplies the lateral part of the foot. And then the plantar nerves supply the sole of your foot. The reason I bring this up is that when you're doing, remember the filament testing, the Sims-Weinstein filament for diabetic peripheral neuropathy? There's a pattern that you test to be comprehensive, but at the very least, what you should do is test in the web space between the great toe and the second toe, the lateral part of the foot and the sole of the foot. And that way it'll get you all three nerves. Okay. There are two large cutaneous, superficial veins, not cutaneous, superficial veins. The one that starts on the dorsal surface of the foot and runs medially all the way up your medial lower extremity and dives in up here is the great saphenous, or long saphenous, whatever you want to call it. There is a small saphenous that starts on the lateral part of the foot and drains into the back of this area of the knee, which is called the popliteal fossa. Popliteal, E-A-L, popliteal fossa. That's where the small saphenous drains. These two veins, they have a lot of importance, particularly the great saphenous, because it's historically been used for bypass surgery. And notice that in veins, they have valves. You know they have valves. We talked about valves and veins. If you take the great saphenous vein out and you're going to suture it into the heart, you have to make sure you turn it upside down so the blood doesn't get blocked by the valves. Alrighty? Or you avoid the valves altogether. Incompetent valves in the saphenous veins produce varicose veins of the lower extremity. We know this thing right here, because we're talking gluteal region. I'll put it up here again. Make sure everybody has a good feel for the sacrotuberous and sacrospinous ligaments. If you look at the nerves that we detected yesterday, I think everybody found the sciatic nerve. And running right with the sciatic nerve is the posterior cutaneous nerve of the thigh. I think some of you guys had it yesterday, yeah. It'll run with it and then surface out here on the posterior thigh. The nerves that supply your Gluteal region back here, these are called cluneal nerves. Of course, would you hand her lung? Because the skin is gone, because the Gluteus Maximus is gone, so are the cluneal nerves. But understand that that's the cutaneous innervation of the buttocks via cluneal nerves. Okay. The sciatic nerve, you see, is in two parts here. It's called a common fibular nerve or common peroneal, either one, and the tibial nerve. Usually these are two nerves that run together, and they usually have a sheath around them. So when you picked them up yesterday, it looked like one nerve. But in fact, that nerve will split down here, just below the knee, or in the popliteal fossa. But there was one cadaver yesterday where the split had occurred up high, And what was that? You were in the middle of the background.
6.
They have both nerves, or separate nerves, all the way up here in the greater sciatic notch. So that split can occur anywhere. Here's the split right here. That split, so this is the common peroneal or common fibular nerve that goes lateral. It comes around here and wraps around the head of the fibula here. It's the most commonly injured nerve in the body because it's right here. It's right here. You can feel it right there. You can feel like a funny bone. It's right there. So people who have fractured their fibula, or a car hits them, strikes them right there, or some machinery strikes them right there, that nerve is the one that gets dinged the most. Okay? Common fibular or common, I like the word common peroneal. So, but you can use either one, you find. Now, the deep fascia of the entire lower extremity is called the fascia. It's called the fascia lata. It's like a stocking. It covers the entire lower extremity. Fascia lata. It's attached to the inguinal ligament up here in the front, around. In the back, it just melds with the pelvis. But that fascia lata is very tough. Laterally, it's thickened. It's thickened. It's called, and at the proximal part of it, there's actually a muscle that's embedded. What is going on with you people sneezing today? There's a muscle embedded in it, and that muscle, when it contracts, puts tension on that fascia lata. So that muscle is called the tensor fasciae. Huh? It puts tension on the fascia lata, called the tensor fasciae. And because it's so anteriorly located, you see it's way around in the front, it helps with flexion of the hip. I'll go more into the detail of it, the motion of it here in a little bit. I didn't mention the thickened fascia lata laterally is called the iliotibial band, or IT band. And it's really thick and tough. It can get inflamed. If you've had IT band, it's very painful moving the lower extremity because it extends all the way from the fascia lata, the tensor fascia lata, and anchors all the way down below your knee. The Gluteus Maximus inserts into both the linea aspera on the femur and the IT band. So you can see the range of the mechanism, the motion of the Gluteus Maximus is going to be lateral rotation, extension of the hip. It's easy to figure out the mechanics of these lower limb muscles. You remove the maximus, and underneath it you've got the minimus. The medius, Gluteus Medius. The Gluteus Medius rises from the iliac crest and inserts into the linea aspera as well. That's the maximus. Let me go to the medius. Here's the medius right here. It inserts into the greater trochanter, not the linea aspera. Sorry about that. As does the Gluteus minimus. They both insert into the trochanter, the greater trochanter. One of the things about the medius is that because it's right here, and it's at sort of the midpoint of the iliac crest, it's not a rotator of the thigh as much as it is an abductor of the lower extremity. And because when you walk, if you stop and think about the mechanics of you walking just a second, when you put your foot down, you have to sort of park your pelvis over the femur. It's like almost like walking with crutches. You have to kind of park your hip over your femur. So that if I stand here and I raise one leg, you see my hips are pretty straight across, right? The muscle that's keeping my pelvis parked over the femur, for the most part, is the gluteus medius. So when you walk, your pelvis doesn't tilt. If the gluteus medius, if the nerve to the gluteus medius, and by the way, it's the inferior gluteal nerve that supplies the superior gluteus. The superior gluteal nerves supply medius and minimus. So if there's damage to the superior gluteal nerve, when you walk, instead of the muscles, relying on the muscles to do that parking for you, you have to physically do it. So what you do when you walk, you have to put your pelvis over the femur. So what you wind up with is a tilt of your pelvis on the affected side, like that. It's called the Trendelenburg gait. Trendel Berg. Trendelenburg gait. Huh?
It spells it on the slide.
Oh, there it is right there. Yeah, so I got it all right. So if you have a lesion in this area, when you get them to raise their one leg, what they have to do is they have to turn their pelvis to park it over there. So the pelvis is slanted. That's how you know you're dealing with lesions of this superior gluteal nerve, or at least the lumbar region of the spinal cord. The minimus is sitting right next to the bone. It's on the bone. When you get through the minimus, you think you're all the way down there. You're going to be surprised at how on the bone the minimus is. Now, in terms of what's superior and inferior gluteal, the demarcating or delineating muscle is the piriformis. I'll talk about that in a second. Here's the tensor fasciae lata. This band is going to be about 2 inches wide here. It is very tough. So it helps with flexion of the hip. It helps with flexion of the knee. It can abduct, abduct. So it has a pretty good range of motion. In this slide right here, this gives all the different ranges of motion, and they're pretty easy to understand. Now, one thing you need to know is, if you're talking about the gluteus maximus here, because it's posteriorly in the back, it extends the thigh. I've already said that. But then, from a flex position, okay, so if you flex like that, it's going to extend the thigh. From a flex position, it will extend the thigh back here. All right? And assist in its lateral rotation, because it inserts laterally, right? Assist in lateral rotation. When you get to the medius here, and the minimus, but it's mostly the medius, it adducts and medially rotates the thigh. How does it medially rotate the thigh? Is because these things are far enough forward that they actually rotate inward rather than laterally. And then where it says steadies the thigh or something like that, keeps the pelvis level with ipsilateral limb, that's the Trendelenburg gait. Here's the tensor fascia. It also does the same thing as medius and minimus. Now, there are other smaller muscles that we have down here. You have a superior and an inferior gemelli, or gemelli, however you want to say it. So if we go from the piriformis, here's the piriformis. Right below the piriformis are 2 little muscles. The superior arises from the spinous process inserts on the femur. The inferior gemelli arises from tuberosity and inserts on the femur. Because they're in the back, they're both lateral rotators. The between the two gemelli is a tendon of the obturator internus. If you look at the obturator muscle, and I'm not sure where it is on this slide here, I can't see it from down here. You'll see it in a subsequent slide. The obturator internus, we know, covers the obturator foramen on the inside of the pelvis, right? That internus goes out and actually goes through the lesser sciatic foramen between the gemelli to insert on the femur. It too is a lateral rotator. And finally, there's a little quadrangular muscle below them called the Quadratus Femoris. It's kind of like the pronator quadratus here in the upper extremity. Quadratus Femoris. The nerve supply to these things is pretty easy because it's the nerve to the superior gemelli, nerve to the inferior gemelli, nerve to the Quadratus Femoris. So you don't need to worry about the nerve supply. Easy. Okay? And they're pretty much all lateral rotators, so that's easy as well. All right. Piriformis muscle defines the region. If it's above the piriformis muscle, it's superior gluteal, nerve, artery, and vein. Below it is inferior gluteal, nerve, artery, and vein. And that's it. Most of the time, the sciatic nerve comes out below the piriformis, but in some people, it can come out within the substance of the piriformis, or it can be above it. Now the piriformis, what does the piriformis muscle do? We're right here, piriformis, we come across here. It is a lateral rotator. You know that because it's in the back. Everything in the back is a lateral rotator. Here's the problem. There are people, especially dancers, not like the Paul, not like the dancers. I'm talking about professional, fine arts dancers, not pure art dancers. You know, they do a lot of rotation of their lower extremities, and a lot of times they'll get a piriformis syndrome, and it's very painful, especially if that sciatic nerve is coming out between the piriformis. The way you, I'll demonstrate at the end on a guy, how you test for the piriformis syndrome. So we get a lot of tendinitis of the piriformis, and you're going to be treating a lot of it in primary care and in the emergency room. Okay. And this is just what I said. Remember the pudendal complex, nerve, artery, and vein, exits the greater sciatic foramen, dives back through the lesser sciatic foramen. So what structure passes through the lesser sciatic foramen, but not the greater? The tendon of the obturator internus. I just said it 5 minutes ago. Somebody's paying attention. There you go. Okay? But if I ask you what passes through both, well, what passes through the greater sciatic foramen, well, it's piriformis, superior gluteus, inferior gluteus, and the pudendal. If I ask you what passes through both, it would only be the pudendals, right? You know, when I make points like that, you're probably going to see it in multiple choice format later on. You know, when I stand up here in the beginning of a lecture and I start talking about like things that can go wrong with your hoo-ha, you're probably going to see that later on in multiple choice format. Not any other way right now, just in multiple choice format. Okay, so pay attention. Here's the illustration of the superior and inferior gemelli with the obturator internus right there. Follow that. You should be able to find that today pretty easily. Very easy to find. Here's its pathway from the inside. Well, actually, this is the obturator externus. Here's the internus coming from inside the belt. The externus is in the front here. So the obturator membrane covers the whole, right? The obturator foramen, except for a defect in the top where the obturator nerve, artery, and vein go through, right? There's a muscle attached to the external surface, the internal surface of that membrane. Obturator internus is what we've been talking about, being a lateral rotator. Obturator internus, that's what we've been talking Obturator Internus, look what it does. It's out here in the outside, so it's right here. It passes it passes behind the head of the femur and attaches to the back. When that thing contracts, what rotation do you think the femur is going to do? Wait a minute, it would be medial rotation if it attached in the front. It goes around behind it, so when it contracts, it's going to lateral rotate as well. It also, tomorrow, defines where you find the obturator nerve. You'll see it come out. The obturator splits and goes around it. Okay? Here's the Quadratus Femoris. It just runs from the pelvis, namely the issue of tuberosity right over here to the, really sort of the crest of the Intertrochanteric Crest. It too is a lateral rotator because it's in the back. Oops. Okay, let's talk about the hip joint. I'll dissect the hip joint today, a knee joint tomorrow, and an ankle joint on Friday. So you'll see the different structures associated with them.
You skipped the slide.
What?
You skipped the slide.
I don't
Oh,
think I
you
did.
did it again. Yeah, you did it again. One more time. Try again. The wrong way. We're going the wrong way. Go the other way. There that goes.
Okay. Well, we've already been over all this crap, so let's go on.
Oh, yes.
Yes, okay. That is odd. Okay. Got a heavy thumb today. All right, so if we look at the hip joint here, there's our sacrotuberous, sacrospinous ligaments in there. If we look at the hip joint, you've got the synovial membrane of the hip, and outside the synovial membrane is the capsule. The synovial membrane, you know, I was talking about the pleura being one cell thick. The synovial membrane, that's another place where you only find one cell thickness, and the synovial fluid is secreted by the membrane, by the way, in case you're separate. So the capsule is around the synovial membrane, and then around the capsule are three strong ligaments, and they're named for the three bones from which they arise. And you see them here. There's from the front, you've got the iliofemoral and the pubofemoral. From the back is the ischiofemoral. I don't care that you recognize which one's which in the lab, but you'll see them pretty clearly. And they are very tight, holding that head of the femur into the acetabulum. Oh, here's the ischiofemoral in the back. Now they're pretty, unlike the rotator cuff up here, where you're dealing with tendons, these ligaments are pretty much have the entire hip encapsulated. You don't see a lot of hip dislocations in one particular way or another. Hip dislocations, because of the depth of the acetabulum, you'll have 99 shoulders to one hip. And the hip usually always involves major trauma, a major impact of something or other. All right. The hip has several bursa around it. And again, it's these bursa attached to or confluent with the synovial sac. So it's pretty easy to tap a hip or to inject a hip. When we remove the acetabulum out of there, well, let's go through this first. The blood supply to the head of the femur comes from a couple of different places. One of them is, here's our, this is called the profunda femoris, the artery. It's a branch off of the femoral artery. It's like, remember the deep brachial up here in the upper extremity? This same thing down here. And off of the deep profunda femoris, or you can call it deep femoral, I don't care. There's a medial and a lateral femoral circumflex. It goes around the head, just like you saw with the axillary artery up here in the shoulder. That lateral femoral circumflex has three branches, an ascending, descending, and a transverse branch. These are easy to find. So that supplies the head of the femur from below. Now here's our obturator artery right here, coming through the obturator canal, that defect in the obturator foramen. It gives off a little branch here called the artery of the ligament of the head of the femur. And that artery runs in a ligament that comes off of the, just write this down for now. The ligament arises from the transverse acetabular ligament and goes to the head of the femur. I'll show you a picture here in just a second. The artery runs inside that ligament of the head of the femur, which is also called a round ligament, if you want to shorten your verbiage. So that artery supplies the very tip of the head of the femur. Already you can see that in a hip dislocation, when you disrupt that ligament of the head of the femur, if there's a fracture in here, the head of the femur has no blood supply, and you can wind up with avascular necrosis of the head of the femur. So now we know two places where avascular necrosis is common: the scaphoid bone and the head of the femur. All right, so this is what I'll do this afternoon. I'll rotate the hip out of the acetabulum. You can see the lunate. I'll use this one over here. You can see the lunate right there. There's the ligament, the transverse acetabular ligament. And here's the round ligament, or the ligament of the head of the femur, arising from it. Here's the transverse acetabular ligament, a round ligament that's been cut right there. And it enters the head of the femur in this little depressed area called the fovea, F-O-V-E-A. I don't know if that's up there or not. Fovea. The middle of the acetabulum is filled with fat, a little bit of fat. So what they've done in this illustration here is they've dissected through the bone from the inside, where the transverse acetabular ligament is still attached. There's the round ligament, there's the fovea. So the artery of the head of the femur, which arises from the obturator, there's the obturator canal right there. It just hops over it and gets in that ligament right there, really easy. This is a skiffy, is what it's known as. It's slipped capital femoral epiphysis, or skiffy. It usually happens in overweight African American males. And if you see right here, you compare this growth plate, this epiphyseal plate, with this one. You see how those two edges line up? This one is slipped off. There's a notch there. So this is skippy. This is going to produce a limp in a teenager, usually African American, usually overweight. Okay? You send them to the orthopedist. You don't try to manage this yourself. If you'll notice also, here's the greater trochanter, and there's an epiphyseal plate there. So the femur is slow to, for all the growth plates to close. Here is a fracture of the anatomic neck of the femur. You see right there where it's collapsed. This is the normal one over here. They put these plates and screws in there to screw them all back together. They don't do this a lot now. Really the preferred method is they take a ball with a shaft on it and jam it. They just go ahead and cut the top of the femur off, and this is all artificial now, the hip arthroplasty. This is one option that could be used in a younger person where you have good bone matrix. This is leg calf Perthes disease.
Please skip this slide.
Oh, I did. Well, let me finish this. Leg calf Perthes disease, what is this? Is a necrosis of the femoral head. It's a slow ischemic necrosis of the femoral head. You see right here how this femoral head is kind of, that's normal. That one is just kind of junky looking, irregular borders, just not pretty. You can see it also in this frog leg view up there. That's just not in good shape there. This is also a limping kid. These kids are usually younger. They're usually not African American. You'll see a skippy and a leg calf Perthes disease in your career. These things are definitely board questions. I mean, board questions. If we go back one here, no, did I go back?
Yeah.
Okay. So this is a normal hip. You see how the edges of the bone are nice? You can see the fovea right there. How they're nice and smooth. In an arthritic hip, you see how it's kind of like cotton, right? That's osteoarthritis there. I say osteoarthritis because it's a weight-bearing joint. You mostly have osteoarthritis in the hips and knees. That's certainly what's going on here. If you look at the characteristics of an arthritic joint, they're all listed there. The joint space narrows up. The cartilage is going, you can't see the cartilage on here, but you would if you scoped it. Irregular weight-bearing surfaces, bone spurs, like that thing sticking down right there. That's a little bone spur right there. These things are all painful. And by the way, on this right here, that's a weenie shadow right there. For a young person, that's a pretty healthy weenie shadow. I'm just saying. Congenital hip dysplasia is something that you're going to run into from time to time. It's not very often, but if you see it, you want to make sure you refer the kids to a pediatric orthopedic surgeon. And there are two different tests that you do on all well child checks of an infant. Every time that infant comes in to see you, you do hip checks on them, up until they're about 6 months of age. And there are two checks. One is the Barlow test, and that's shoving their hip up and then rotating it in. I don't do that one. I do the Ortolani, which is essentially you have them on the back, you grab them by their legs, you lift their legs up, and you bring their legs up like this, put your hands in their hips and rotate them laterally, kind of like frog leg them out, spread their legs. And if there's hip dysplasia, in other words, a weakening of the hip, you'll feel a little clunk as you rotate their hip out. So those are the Barlow and the Ortolani tests for congenital hip dysplasia. You can see in an infant, not much of the pelvis or the femoral head is ossified yet. There's still most of the cartilage. Okay. Hip dislocations, if they occur, they're usually posterior, like this one right here, and it's usually due to a person sitting in the front seat of a car and they hit something and you get jammed into the dashboard and your hip gets driven out the back of the acetabulum. That's the standard hip displacement. You can see it over here in this young person. You can reduce a hip in the ER. It takes a lot of work and a lot of pulling and relaxation, but I prefer to get the orthopedic surgeons to do this because there's a lot that can go wrong trying to get back in. I will tell you that the acetabulum has a labrum around it, just like the glenoid cavity does, cartilaginous labrum that helps extend the depth of the fossa. Here's necrosis of the femoral head. You see that it's just it's hyperdense. It's going away. You can see it as this density. This should all be the nice same color. Instead, you've got all this darkened stuff in the middle here. That's not good. That's going to be a replaced hip. Trochanteric bursitis. So here's your greater trochanter. This thing that you feel right here is your greater trochanter. There's a bursa underneath the muscle there called the trochanteric bursa. A lot of times in repetitive movement or motions, like you're playing softball all weekend or something, whatever, you're overexerting yourself in terms of walking, climbing, hiking, whatever. These bursa can get inflamed. So the way you treat this is, and you can tell it's trochanteric bursa, all you gotta do is put your hand on it and get them to move their hip, and it's painful. What you can do with these things is inject them with steroids. You lie on the side with the affected hip up. You load up a syringe with an 1.5 inch long needle, and you put it all the way into the bone, till it contacts the bone, then you pull it back a couple of millimeters and inject the steroids. And that's a pretty good, lidocaine or Marcaine goes with it to numb the area. But these things are pretty easy to hit with a needle. You'll be injecting these. Here's Trendelenburg sign where you do the hip there. Okay. Now, where you would do an IM injection, an intramuscular injection, is either in the deltoid area up here or the hip, the gluteal region. Now, what you don't do is, if you think of your butt cheek here and divide it into quadrants, all IM injections in your butt cheek should be in the upper outer quadrant. And the way you do that, you've got your needle here in your syringe. What you do is you put your hand in the, as they bend their leg here, you just put your thumb right there. I would do this upside down with this hand. Well, like that guy. So you put your hand right here, your thumb right here on the inguinal ligament, your anterior superior iliac spine essentially, and you shoot between these two fingers right here. And if you shoot right here, you will never hit the sciatic nerve. Injecting into the sciatic nerve, you just better call an attorney because you've got a lawsuit coming. Always inject in the upper outer quadrant. This is a couple of things going on here. This is shingles. This is what I was trying to tell you before. When you have shingles following that dermatome, nice dermatomal pattern, shingles are characterized by little fluid-filled blisters that are excruciatingly painful. Because of the lymphatic drainage of the Gluteal region, you're going to get swollen lymph nodes in the inguinal region around front. This guy, you can see the inguinal nodes up there in the top. This guy also has a touch of phimosis that I have to deal with. Fracture of the pelvis, I mentioned this before, 50% of the people will die. They die because of what arteries coming right there. What artery do you find right there? The internal iliac, crossing that arcuate line of the pelvis. So that's the artery that's going to get you right there. Sciatica is an inflammation of the sciatic nerve, and you'll see this a lot. People come in complaining of that sort of thing. So to test sciatica, the way you want to do that, let me get Paul down here. If you'll just sit there and face that way. All right, so sit up here. Go ahead and sit up on the thing. So the way you test it for the Piriformis syndrome, remember, I'd say look at where the piriformis is, and you know, you have to visualize where the greater sciatic notch foramen is, where the piriformis is. If it's piriformis syndrome you're thinking of, or if it's sciatica, both of them will give you the same level of pain. Take your hands and say, I'm going to press on your butt. Just tell me if this is painful. Take your fingers like that and just jam into his butt. That's where the piriformis is, and that's where the sciatic nerve is, right? If either of those inflamed, he'll say, that hurts, okay? Now, to separate them apart a little bit, what we're going to do is we're going to put a stretch on the sciatic nerve. The sciatic nerve runs all the way down to the foot. If I straighten his leg, that stretches his sciatic nerve back there, it will be painful. Now, note that his body is here and his lower extremity is here. Is at 90 degrees, right? So this is the sciatic nerve. This is the straight leg raised test sitting. When I straightened his leg out, it hurt. Now, if you'll lie back, and if you straighten the leg, come on up here, if it's piriformis, that won't hurt. If it's sciatica, it will. Now, this is where you can tell whether somebody is bluffing you or not. And you'll have a lot of patients bluffing you, trying to get Lortabs out of you. Is that with his head back, I'm gonna raise this leg. In clinic, you call this a leg, not just that. I'm gonna raise your leg here. And so usually if it's sciatica, real sciatica, if he had a straight leg raised test sitting, he will have a straight leg raised test supine, right? If it's real sciatica. Now, if he's bluffing with me, when I say, I'm going to raise your leg, tell me if it hurts in your back. And I start raising his leg, you get about an inch off of the table, and he starts screaming bloody murder. Okay, so look at the angle here. It's like 10 degrees off of straight, right? But then I sit him up, and you do the line, and then come down to the, you do. And then I come down here and I say, okay, now I'm going to straighten the leg here. Tell me if it hurts in the back of your knee. And it doesn't hurt him right here. Because I distract him. I say, tell me if it hurts in the back of your knee. They may say, yeah, it hurts in the back of my knee a little bit. But if it was true sciatica, look at the angle of his knee, his leg. I would have lit him up, right? But if you have them sitting there and you can straighten their leg all the way, that's 90 degrees. Sciatica is going to be painful sitting or supine. Malingerers or drug seekers, it will be positive supine, but not sitting. And that anatomically can't happen. Okay? Let's go to the lab. I think that was it, wasn't it?
Yeah.
Okay. So in lab today, on both extremities, just remove the skin all the way down to the toes. You don't have to go out onto the toes. Just take it all off, okay? Down to the fascia lata.
What?